Great. Thank you so much, everyone, for joining us this evening. We are happy at Sava Library to partner with Stony Brook Medicine and Dr. Patricia Coyle talking to us this evening about the topic of multiple sclerosis, a subject indeed where knowledge is power. The more knowledge you have, the more power you have with this. Welcome, Dr. Coyle. I'm going to get my screen ready now with the PowerPoint presentation. Bear with me just a moment, and then we'll start that PowerPoint.
So we had a little bit of a glitch technically, but we got my slides up and I'm ready to go as soon as we have the set of slides. So I'm going to be talking about multiple sclerosis, or MS, this evening, which is a major neurologic disease. Can I have the next slide, please? These are my disclosures. Next slide. So MS is the major acquired neurologic disease of young adults. It's a major neurologic disease, but it is confined to the central nervous system, or CNS. That's the brain, the spinal cord, and the optic nerve. It doesn't affect muscles. It doesn't affect peripheral nerves. There's no pathology in the heart, the lungs, the kidney, the gut, etc. It's confined to the central nervous system. And there are a number of very interesting and relatively unique features to differentiate it from ALS, for example, or Alzheimer's disease, or Parkinson's disease, for example. Next slide. First of all, it's a female predominant disease, currently about 3 to 1, 75% female, 25% male. That's increasing over time. MS is increasing among women. We don't really have an explanation for that. Unlike most of the major neurologic diseases, this is a disease of young people, not of aging. It doesn't become more common with aging. 90% of MS patients will present between the ages of 15 and 50. The average age is late 20s, about 28 to 30. When you look at pediatric MS, which is defined as onset of MS before age 18, that's about 2% to 5%. It's actually fairly uncommon. If you go to the age extremes, under the age of 11 or 10, that's well less than 1%. I think you may have in the literature a case at age 2, but that's distinctly unusual. For pediatric MS, the bulk of the cases are adolescents around puberty. MS increases. So too, as you look at older age onset, it's estimated 10% or less of MS will present after the age of 50. And if you look at onset age 60 or older, that too is less than 1%. Yet there are individuals who state there's no prior history till they present with issues even in their 70s. One question you may ask is, are they forgetting about some very mild neurologic issues that in retrospect could have been MS years earlier, because you can have MS attacks spaced out by many, many years. So this is hitting people in their prime, ages 15 to 45. Next slide, please. Another key feature of MS that's so different than other major neurologic diseases is it's so highly variable. No two patients are alike. You range from the mildest end of the spectrum to rarely a very severe end of the spectrum. No two patients are alike. So every patient is a little bit different. This is classically a white person's disease, Northern European, Scandinavian background, greater than 90%, but we're seeing MS in blacks, in Hispanics, in Asians. When I went to medical school, we were told Native Africans never got MS. Now there are hundreds of documented cases of Native Africans with MS, so it hits almost every national group. We don't think of people dying from MS, to be honest. There's not a major mortality rate, but untreated MS can create morbidity. Next slide. Now, when I say that there's no death rate from MS, that's obviously not completely true. Overall, they would say the lifespan is shortened about 6 to 8 years with MS, but that's reflecting very disabled patients. If you have a very disabled patient, you're going to be more vulnerable to aspiration pneumonia, to urosepsis, to having a bladder infection go into the blood and make the whole body septic. You're going to be more apt to get decubital ulcers, and of course you're going to get a higher death rate in very disabled patients from whatever cause is doing that. So when we think about death in MS, very disabled patients are going to have secondary complications and a higher mortality rate. Extremely rare that MS itself can kill somebody. In my whole career, I had one patient, a 41-year-old gentleman that I was following. He needed a cane, but was mildly affected, no medical conditions, and he died in his sleep. And because they didn't know why he died, he went to autopsy, and he had a deep brainstem acute lesion of MS. So in my entire career, that's the only patient that I've ever encountered where I can feel comfortable saying MS killed this person. And of course, depression is a comorbid condition that's increased in MS, and obviously you can die from suicide. But really, it's not mortality, it's morbidity of untreated MS. That untreated MS can cause disability that leads to difficulty with walking, difficulty with having a career or holding a job, and cognitive difficulties. I think this whole picture, though, I would be very optimistic, is changing in the era of the disease-modifying therapies. Next slide. So when we look at the spectrum of MS, we start with what is the at-risk population? Can anybody get MS? A very provocative recent article suggested 14.7% of the population was genetically vulnerable to getting MS. Now that was by mathematical formulas over my head by a pretty good biostatistician who's also a neurologist, but we really don't know the answer to that question. Can anybody get MS, or are you defined to a subset that's vulnerable to getting MS? That would be a very important question to answer. Then we know MS can be silent. How do we know that? Autopsy studies. Obviously, we don't have a heck of a lot of autopsy studies, but if you extrapolate, the autopsy studies would say that about 25% of people who have MS pathologically never show any signs of it. That would be 1 in 4 have the disease, but it's so mild they never have any expression of it. So that's very interesting. I've said I can't look at anybody and guarantee they don't have MS if you tell me 1 in 4 MS cases are silent and they actually have the disease. Of course, if you go through a workup and it's entirely non-supportive, then I think you can feel pretty good that you don't have MS. So there's silent MS. That's the mildest form. They never actually have anything. Then there's an entity called radiologically isolated syndrome, or RIS or RIS. That's a young individual between the ages typically of 15 to 50 who happens to get a brain MRI because they have headaches, because they had a mild concussion, because they volunteered in a clinical study to be the healthy control getting a brain MRI. And lo and behold, it comes back very abnormal with lesions and it looks like MS. But they don't have any clinical history for a neurologic disease, and their neurological exam seems quite normal. That is a RIS. That is a radiologically isolated syndrome. And I can tell you in the global databases, within 5 years, 34% of RIS patients declared themselves as having MS, and within 10 years, 51%, okay? Then we have symptomatic MS that includes a prodromal stage that can go 5 to 10 years before they present with a neurological issue. This is very interesting. It's not unique to MS. Most of the neurodegenerative diseases have a prodromal state where there's something going on health-wise not quite right. But it's not neurologic, it's not clearly neurologic, they haven't declared themselves as MS, but that may track back the disease as long as 10 years before the clinical presentation. Then we have the clear MS presentations. These are the 4 phenotypes. There's clinically isolated syndrome, or CIS. That's the first CNS inflammatory demyelinating attack. That's the patient that has an optic neuritis, with decreased vision in one eye. That's the patient that has a transverse myelitis with an inflammatory spinal cord lesion that gets numb in the legs or numb and weak in the legs. That's an isolated brainstem syndrome where somebody develops double vision. They aren't moving their eyes right. And that CIS first attack patient, it may be the first attack of relapsing MS, or it may not be MS. You categorize them as low or high risk for MS. You would treat CIS high risk, by the way. And that all depends on the MRI scan. If they have scattered lesions that aren't explained, that aren't explaining their CIS attack, and you've ruled out everything else, they're CIS high risk, and you would treat them as though they had MS. And then there's established relapsing MS, the major form of MS. That's how 85 to 90% of MS patients present, with attacks, relapses, exacerbations, flare-ups, and in between the attacks, the individual is completely stable. They don't seem to be changing. Then you have the unusual form of MS, which shows slow worsening from onset, primary progressive MS. That's only 10% to 15%. That does not present with an attack. That presents with gradual worsening as you look over a year. They're typically gradually having greater difficulty with walking, gradually developing weakness of the legs. That's an unusual form of MS. Progressive MS is gradual worsening, believed to represent the neurodegenerative injury to synapses, axons, the nerve fibers, and neurons. And then there's secondary progressive MS. Every relapsing patient is at risk to transition to secondary progressive disease, where they now clinically gradually worsen independent of relapses, particularly at midlife, around age 45 to 55. We hope our treatment is going to prevent this. We know it's delaying it for sure. The big issue is, are we going to prevent it, or are we simply delaying it? So clinically isolated syndrome, relapsing MS, primary progressive MS, secondary progressive MS, those are the 4 recognized clinical phenotypes. Radiologically isolated MS is not yet considered an MS phenotype. It may be in the future. Prodromal MS is not yet considered an MS phenotype. It may be in the future. Next slide. What causes MS? Well, you want to know, if I were giving this lecture 30 years ago, I would say the same thing. Genetics, environmental factors, and the host immune system attacking its own body organ. First of all, MS is not an inherited disease. There's no gene that passes on MS. But there are genes associated with MS. More than 233 have been identified that are risk susceptibility genes, much fewer genes that seem to protect against MS, and genes that may be associated with disease severity. So it's believed that there's an enriched genetic pool that might make a subset more vulnerable to develop MS. But the genes seem to be trumped by environmental factors. Environmental factors are very important. At least in whites, in Caucasians, vitamin D deficiency significantly increases risk for MS. Keep in mind, it's been estimated maybe 80% of Americans are vitamin D deficient. You should know what your vitamin D level is, and if you cared about decreasing risk for MS for young people, you would correct it to normal levels, okay? Epstein-Barr virus exposure. There is not a single case of adult onset MS that doesn't have antibodies to Epstein-Barr virus. In other words, there's not been a single case documented of adult onset MS who's not been exposed and infected to Epstein-Barr virus. EBV is a herpes virus. Once it's in your body forever, forever. It never goes away. Tobacco use and smoking increases risk for MS. Increases risk for MS. Tobacco smoking has no redeeming qualities except maybe decreasing risk for Parkinson's, okay? That's about it. Otherwise, there's nothing good about it. Vaping is probably worse than cigarette smoking. Taking marijuana and smoking it is bad. You do not want to put chemicals in your lungs. It causes a pro-inflammatory state. So that's very important. Next slide. Ultraviolet radiation and sunlight seem to decrease risk of MS. That's why there's so little MS at the equator, and it seems to increase as you move north and south. Increased salt intake, that's controversial at the current time. Adolescent obesity increases risk for MS. Adolescent obesity. Remember, obesity is a pro-inflammatory state. You have a whole bunch of adipokines and cytokines, and it boosts inflammation within the body. And probably a permissive gut microbiome. What do I mean about that? All of our guts have microbes growing in them, a little bit unique, every individual. There may be gut microbiomes that promote development of MS and others that combat it and fight against it. And there's ongoing studies in that regard. And then you have the host immune system attacking its own body organ, the central nervous system. Next slide. So MS is fascinating. There are low, medium, and high risk zones. It's not dispersed the same way over the entire globe. That's sort of what an infectious disease would have. There's little MS at the equator. It increases as you go north and south. There have been clusters and epidemics. Migration studies say where you grow up, particularly in the first 15 years, determine your risk of MS. The most recent data says almost 1 million individuals in the US are diagnosed with MS and over 2.5 million worldwide. And MS is on the rise among women. Next slide. This is genetics. As I said, there's no gene that passes on MS. Only 20% of individuals will have any family member with the disease. There's no single gene. The risk typically in the white population is about 1 in 750, 0.13%. If you have a first-degree relative, particularly a sib, more so than a parent, your risk goes up to about 2.5%. So that increases the risk, but honestly, environmental factors probably trump that. Even identical twins, one has MS, the concordance rate is only at the most 40%. It's not 100%. So genes don't rule the day with regard to MS. Now, if you took MS patients and probed their relatives, you did brain MRIs, you did spinal taps, you would find a minority proportion that were abnormal. They would show abnormalities that would suggest an occult MS. Of course, we never do that, and there's not a point if they never have any issues. Next slide. This is a very interesting study. It was published in 2005, but it looked at the French West Indies. That's not a white population. They have very little MS compared to the United States. They looked at French West Indies, Martinique, and Guadeloupe, who moved to France and lived in France for a while. Next slide. Then they came back to the French West Indies. Their rate of MS was twofold higher than those that had never left the island. Just living in France increased their risk for developing MS, particularly if they moved as a child, particularly if they moved before the age of 15. How could that be? Well, they concluded this was speculative. It was a hypothesis. One dramatic change that had happened in the last couple of decades was there used to be a very high intestinal parasitic rate of little kids. Parasitic infections would create an immune response that would be combative to MS. It would be favorable to fight MS. They've cleaned up their act. They no longer have parasitic infections of little kids. And they hypothesized in this article that that made the French West Indians more susceptible to developing MS when they were in an environment where MS was promoted. They lost a protective factor. So that's kind of an interesting speculative interpretation. Next slide. What about this Epstein-Barr virus? As I said, this is pretty remarkable. There is not a single adult onset case that doesn't have antibodies to Epstein-Barr virus, not one single adult case. If you have clinical illness with Epstein-Barr, which is mononucleosis, it's the major cause, it's not the only cause of infectious mononucleosis, you have a twofold increased risk of developing MS. EBV infects B cells. They are part of the immune system. There are studies where they have banked blood samples and the person subsequently developed MS, and they went back and looked at their banked blood samples in the months before, sky-high titers to Epstein-Barr virus in that person that was then destined to come down clinically with MS. So there's a very interesting story here that people are studying that needs to be revealed to get new insights into MS. Next slide. This is just a cartoon that indicates what we believe happens in an outside-in theory of MS. What we do know, if you activate immune cells, lymphocytes, they penetrate into everybody's central nervous system. But in a healthy control, they penetrate in and they penetrate right out again. Not in MS. Number one, you have larger numbers of activated immune cells, lymphocytes, in the periphery, in the blood. Secondly, when they penetrate in, they don't leave. There's some sort of signal or recognition or something happens, they begin to attack the tissue. And they begin to cause those lesions that you can see on an MRI scan. So there's no doubt that the host immune system is attacking its own body organ, the CNS. And that's why the vast majority of disease-modifying therapies are immunosuppressive. They all modulate the immune system. Most of them are immunosuppressive. There's also an inside-out theory. There's evidence for a primary abnormality within the central nervous system, perhaps at the level of the microglia cell or the oligodendrocyte, that may actually be calling in the systemic immune cells. That is the inside the CNS problems go along more with the neurodegenerative, progressive component of MS. So we see this focal inflammatory component from the systemic immune system for relapsing MS, causing those lesions on the MRI scan. And we see the in situ immune response of CNS cells that seems to be responsible for the neurodegenerative injury that translates to progressive, gradual worsening MS. Next slide. So, untreated MS does not remit. That's why I don't like the term relapsing remitting. Now, obviously in the spectrum, you can have very mild MS, but there's hidden damage. So the concept that relapsing patients remit if they're not having an attack is false. There's microscopic damage occurring in any untreated patient. Now, maybe it's at a low degree and you have great reserve, but an untreated MS patient has ongoing damage, microscopic damage, disrupting circuitry in the brain, disrupting nerve conduction. If it hits an eloquent area, that's a clinical attack, but there are ongoing pathologic damage and changes in untreated MS. Next slide. The pathology of MS reflects CNS inflammation throughout the disease course. Focal inflammation with breach of the blood-brain barrier and contrast-enhancing lesions in relapsing MS, neurodegenerative injury inside the CNS in progressive MS. In those macroscopic lesions that we see on the MRI scan, early on there's inflammation and edema, removal of myelin, those are the fatty sheaths that allow rapid nerve conduction along the axon nerve fiber, damage to the axon, even transection in some cases, reactive gliosis that's forming a scar tissue to really screw things up more, variable loss of the oligodendrocyte, the myelin-making cell in the CNS, and some variable death of neurons also. There is remyelinization, there is repair, not in everybody. There seems to be 20 to 30% that can't repair. Unfortunately, the repair is not good enough. It can't overtake the damage factor, and there are a number of treatments that are being looked at to try to boost repair and remyelinization to try to improve fixed deficit. Next slide. So how do you make the diagnosis? It's said MS is a clinical diagnosis. It would be a disgrace to make it without a full workup. These criteria were put forth by Shoemaker in 1965, and they still hold. The clinical criteria: the right age, not too young, not too old, clinically white matter disease, that would be motor, sensory, coordination. However, there's a lot of gray matter involvement in MS. Lesions disseminated in space and time. You can never have X marks the spot. If your whole problem could be explained by a lesion in the one area, that's not going to be MS. I've seen patients misdiagnosed as MS when I examine them and say, this is all explained by a spinal cord lesion in the thoracic area. It can't be MS. You have to find evidence for dissemination in space and time. Objective abnormalities on the exam, hard to make a case if the exam is exquisitely normal, a relapsing or progressive course, and no better diagnosis, which means you do work up the patient. Everybody deserves a workup. Next slide. So relapsing MS can present with a unilateral optic neuritis, monocular vision loss with pain, an incomplete spinal cord syndrome, a brainstem syndrome that might produce acute double vision or trigeminal neuralgia, tic douloureux in a young person, a cerebellar, a syndrome, paroxysmal attacks lasting a minute or two that occur maybe a dozen times a day. Progressive MS typically presents with a progressive spinal cord syndrome, difficulty with walking and leg weakness. Rarely it can be progressive vision loss, progressive cognitive loss, progressive brainstem syndrome, a progressive hemiparesis, weakness on one side, or a progressive cerebellar incoordination ataxia syndrome. Those would be rare presentations for primary progressive MS. Next slide. This is the workup, selected blood studies that help to rule out other diagnoses and co-diagnoses. At Stony Brook, we believe strongly in spinal fluid, and we're looking for CSF, spinal fluid specific oligoclonal bands, an independent abnormality ultimately found in greater than 95% of MS individuals. And then the MRI scan, which can be incredibly helpful. These are the key diagnostic factors to try to truly make an accurate diagnosis early. Next slide. This is an MRI scan that's looking at T2 flare. This is the first sequence that I look at because it will elucidate all the abnormal areas, all the damaged areas. This is abnormal water content. It doesn't tell you what the pathology is, but those hyperintense white areas are abnormal. Those are lesions. T2 flare is the first sequence that I would look at. This happens to be an MS individual. All that hyperintense white staining is abnormal brain tissue. Abnormal based on water content, but would be lesions. Next slide. This is a contrast study. You inject gadolinium contrast dye, you wait at least 5 minutes, and you see if it leaches out into the brain. Why is that helpful? What we're pointing here is that the hyperintense lesions are actually the contrast dye that have leaked out. There's a focal breach of the blood-brain barrier. This dates the lesion. This is active right now. Otherwise, you don't know how old the lesion is. This is saying there's a break of the blood-brain barrier. This is characteristic of relapsing MS and young MS. These are active lesions, multiple lesions. This would be a hot, active case of MS, likely relapsing MS. Next slide. And this is spinal cord, and the arrow there is pointing to a lesion in spinal cord. You know, a lot of stuff can give lesions in the brain MRI. Very little give lesions in the spinal cord. After age 50, you're not supposed to use a brain to make a diagnosis of MS because you start to see lesions in otherwise healthy controls, or you have hypertension, or you're pre-diabetic. You start to see lesions. The older you are, the harder it would be to have a normal brain MRI, but not the spinal cord. You don't see any lesions with aging. There aren't a lot of stuff that produce that. This would be highly supportive for MS, not diagnostic, but highly supportive. Greater than 90% of the spinal cord imaging is abnormal in the MS population. Next slide. MS therapy. I can't overemphasize the value of good lifestyle choices and a wellness program to help improve aging of the central nervous system. And that's fundamental to doing well with MS. You can be on the best treatment, and if you're smoking, you're following an unhealthy lifestyle, you're sabotaging your central nervous system. You're going to age more rapidly, and that's a problem with MS. So wellness, health maintenance, vascular risk factor control. Comorbid diseases make MS worse. Very important that they be identified and optimally managed. Doesn't have to be by the neurologist. If you have hypertension, if you have depression, you can't let that go untreated. That needs to be dealt with, optimally controlled. And then, of course, symptom management treatment of the acute attacks of MS, and then the disease-modifying therapies. Next slide. Honestly, right now we have over 25 products if I count all the generics. They're all approved for relapsing MS. There's only one DMT approved for primary progressive MS. So you see the lack of treatments for progressive MS. They cover 10 distinctly different mechanisms of action, but they all manipulate the immune system. They all affect the immune system. Many of them don't act inside the CNS, yet they can have a potent effect on MS. One way to divide them are the needle injectables, the orals, and the monoclonals that are the high efficacy. There is a final agent, mitoxantrone, a chemotherapy drug that we never use anymore in MS, even though it's on the books for a variety of reasons. We really would not use that anymore. Next slide. CNS repair strategies. We don't have a proven CNS repair strategy to date. That having been said, we're doing studies in MS on CNS repair. So that's good. This isn't in the test tube. This isn't in animal models. This is in MS individuals. Things like stem cell transplant, things like neurotrophic factors, things like immune modulation to boost remyelinization, to block CNS repair inhibitory factors that are interfering with CNS repair. We're actually in multiple studies. That's a good sign. I think it's honestly just a couple of years away before we have our first established. We had a couple of failures just in the last couple of months. Next slide. Removal of the glial scar, gene transfer, antioxidant agents, remyelinating agents, and an interesting gold nanocrystals that you drink, you swallow, oral, that can boost repair based on animal models that are currently in tests in MS. So a bunch of different techniques. It's very promising, but none documented at this point in time. Next slide. So to summarize, MS is the major acquired neurologic disease of young adults. Recent studies are giving us new insights into this disease. We're learning more and more about it. I still don't have the crucial answers, but I have a way better understanding than from 30 years ago. And we've seen in the last 3 decades multiple disease-modifying therapies. That's a huge success story. I can tell my relapsing MS patients now, if you follow things properly, you should be able to live a normal life. Before the era of the disease-modifying therapies, I had no treatment. It was a crapshoot. Couldn't tell what would happen. We would try to treat it. You had steroids, you had immunosuppressives, you had no disease-modifying therapies. So we are really lucky from that point of view. And I think as we finally get to understand the etiology, and as we develop CNS repair strategies, and as we get really effective treatments for progressive MS, we are going to get even better and better therapy. So I'll stop there and I'll be happy to open it up to any questions.
Great. So, Dr. Coyle, I'm going to stop sharing the screen. Is that okay?
That's fine.
That's great. And then let me see if I can just unmute everyone. Let's see. Ask all to unmute. Here we go. Now, hopefully you all have the ability to unmute yourselves. Give that a try if you can. If you have any questions, it looks like I'm starting to see some folks unmute. That's good. Excellent. Any questions for Dr. Coyle? That was an amazing presentation. Thank you for some hope. It sounds like our newer drugs are helping address the issues that are, at the base of this disease that are causing it. So, any folks have any questions? Christine, please go ahead.
Can you hear me?
Yes,
Yes.
we can.
Yes. Okay. I'm a therapeutic horseback riding instructor. And in the past, I have treated mostly women, not treated, but have mostly had women clients on the horses for therapeutic reasons. Is there any research on that and how that may help lessen symptoms or
Right. So that's
part of the wellness plan?
That's called hippotherapy, and there actually have been some research studies suggesting a benefit that can be extremely helpful, particularly for patients that may not be upright a good part of the day. So hippotherapy can be something that's very good, particularly for very disabled patients. So it's a recognized form of therapy. I'd say it doesn't have a lot of research, but it's definitely been done. Many people believe very passionately in it. So it's quite, valid, I think.
And I've seen the results of it. I don't do hippotherapy. I'm a therapeutic riding instructor. But even with that, I've seen results in the women that I have encountered over the years.
Well, keep in mind, part of a wellness program is exercise. It can be aerobic, it can be weight training. The more active you are, that's part of a wellness program. That's only beneficial to central nervous system health.
Mm-hmm. Okay, thank you.
Any other questions out there? Yeah, Alex.
I have one kind of random one, actually. I find the whole exposure to the Epstein-Barr virus as being a risk factor very intriguing because from my teenage years, I actually had exposure to Epstein-Barr without mono symptoms that I believe had led to chronic fatigue and all these other kind of immune responses. Have you guys been researching or finding anything that can help to reduce the symptoms and risk factors from the Epstein-Barr virus?
So obviously, this has been a pretty interesting area of research. So one of the first questions they asked, is Epstein-Barr virus infecting the central nervous system, invading the CNS, and could MS be an Epstein-Barr viral infection syndrome? That basically does not appear to be the case. So you don't typically see EBV to be able to be found within the CNS showing active infection of central nervous system tissues. The way that they're interpreting the data is that it seems to be a required immunological cofactor to develop MS. That if you're adult onset, you can't declare having MS without having prior EBV. So they're asking, what immune changes does Epstein-Barr virus do that would allow it or promote it to occur? Now, there's not good data in pediatric MS. The one study reports about an 80% rate of positivity in pediatric MS versus 30% with pediatric controls. But these were not well-studied cases. They weren't really interrogated very strongly for EBV infection. I think that really needs to be done. Some people have taken this to the point of talking about, could we get a vaccine for Epstein-Barr virus? And there are actually some studies looking at T cells that are primed to Epstein-Barr virus as a treatment for MS. But I think a vaccine, which is the one way to prevent an infection, as we know, that's kind of draconian for Epstein-Barr virus, where it's a universal pathogen and it's around everywhere. You'd have to vaccinate every single person. And whether that would prevent MS or not, I don't know. But they don't think that they could get the bandwidth to vaccinate everybody to prevent the disease. So it raises a lot of interesting questions.
And I swear, with my Epstein-Barr diagnosis in my late teens, that it had caused like decade-long chronic fatigue-like symptoms, which they say is immune response.
Yes,
and there's a vitamin that I have been taking that I swear has cleared all of that. The AHCC, which is like a mushroom derivative, I was on that for a couple of years, and once I started taking it, one of the side effects was that fatigue was gone, and I never had a titer.
So that's very interesting. This is an area that is not terribly well studied, but there's no doubt that there can be, look at COVID. They have long haul COVID now that they're trying to get a handle on. People can get the same infection and somebody has lingering problems and somebody else is hardly sick and recovers immediately. We don't really fully understand that, but there's something there.
Right. Yeah, it's very interesting.
Yeah.
Any other questions?
I would actually like to say thank you to Dr. Coyle. I always, because the people I met with MS are always in their 40s and up. I never realized that this.
Oh, there are people walking around with MS you would never suspect they had a disease.
Right.
That's changed the face of MS, I can't tell you.
Mhm. So it's opened my eyes up to a lot of other, I guess, just to be open to other things when I see younger people with things
Yeah.
you're not really sure what they are.
Listen, this is a very interesting thing. When we talk about the invisible symptoms of MS, fatigue is an invisible symptom. MS individuals can have such tremendous fatigue, they can't work. Yet they look great. So there's a huge discrepancy, and people are sort of eyeing them like maybe there's something wrong with this person. Yet anybody that's experienced horrific fatigue can understand how bad that can be. So it's very interesting. We don't fully understand the impact of these invisible symptoms of MS.
Right. Thank you very much.
You're welcome.
Any other questions out there? Looks pretty quiet right now. All right, excellent. Dr. Coyle, I just have to say thank you. On behalf of Save a Library and also on behalf of our audience, what a great in-depth presentation on what this disease is, how it kind of surfaces, what goes into supporting it, and making the environment just right for it to erupt. Thank you so much. Like I said at the beginning, knowledge is power.
Right.
And, oh my goodness, it just sounds like if you at all suspect it, go get checked.
Absolutely. Absolutely. You want to be diagnosed early as possible.
Yeah, definitely. All right. Well, thank you so much. I think, the more people we get aware of this and the more that knowledge gets out there, the better chance we have of catching those early cases.
Great.
So thank you once again, Dr. Coyle. Thank you
very much.
Medicine. We appreciate it. And thank you everyone for joining us here. Just as a side note, if we're talking about wellness, tomorrow evening, we're conducting a Zoom with Long Island Community Hospital on the Mediterranean diet. You can sign up for that program right from savillelibrary.org and just go to our programs and events calendar and click on tomorrow. You can sign up and you'll see me here on Zoom again with another medical professional on the Mediterranean diet. So once again, thank you so much, Dr. Coyle. We appreciate your help this evening.
Thank you.
Amazing presentation. Thank you.
Thank you. Take care. Bye-bye.
Take care, everyone.
Good night.
Thank
Bye-bye.
you. Good night.